A very good evening. Very good evening. Welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. Myself, I am Dr. Ramyashree. I am Obgyn Guru on this platform. So today we are having the doubt solving session. So I'll be discussing all the queries whichever you have in this session. So guys, come on, shoot. I'll be answering every queries whichever you have, right? First and foremost, is my voice audible and clear? Very good evening. So whatever are your queries pertaining to obstetrics and gynecology, feel free to express so that I can help you out. Once I speak about your queries, I'll also speak about the queries which I got through Telegram or Telegram. So I'll answer those queries also. First, I would like to see the queries which you have, followed by I will. Okay, app is not working. Yeah, there is a small technical issue. I think they're looking after it and very soon they'll inform you back. Okay. Yes, Rocky. So there are updates in the upcoming notes of NEET 2023 because we have Williams 26th edition. So you have to just keep in the app. I will post the video which contains all the upcoming updates. So there are updates in the pregnancy and antenatal care, hypertensive disorders, missed abortion. So whatever it is, I'm going to post it as a single video so that you can just go through that video and write down what are the updates. As well, cervical cancer screening methods, WHO SAGE committee giving us the single HPV vaccination for 9 to 14 years. So there are some updates, guys. There are some updates. So next, how does fibroid appear on X-ray with popcorn calcification? So fibroid, when it has calcareous degeneration, so then it can appear on the X-ray as a popcorn calcification. But usually we don't do to pick up fibroids X-ray. So on X-ray it can be an incidental finding. Next, I have a question from Ketan. How can we differentiate between maternal and fetal blood? Right. So the qualitative test. So maternal blood is maternal blood is having hemoglobin A2, whereas fetal blood has hemoglobin F. So this hemoglobin F is resistant to the acid or alkali. So whenever you apply acid or alkali, the maternal bloods will shrink or dissolute, but fetal RBCs will stand out. So that is how I can differentiate. So the qualitative test to differentiate the maternal and fetal hemoglobin is apt test where we use sodium hydroxide as a reagent. So maternal RBCs will die or become ghost-like or dissolute, whereas fetal RBCs will stand out, right? So this is also called as Singer's alkaline denaturation test. Next, we also have quantitative test to differentiate, quantitative test to measure the feto-maternal hemorrhage, that is Clare-Bedke test. So in Clare-Bedke test, you use it's also called acid elution test. Here you use citric acid as the reagent. Okay. Next. Mazhar, NEET PG rank of 12,000. Yes, it's possible. Just see for second counseling and third counseling. Probably not in first counseling, but second and third counseling, you can have a watch. Okay. So when there is a break in the cord while you are doing the Brandt-Andrew method, your next step should be going for manual removal of placenta. This was also asked as a question in the NEET, last NEET. So while you are doing Brandt-Andrew method, if suddenly the cord disrupts, then you can go for manual removal of placenta. Okay. Right. So I hope I have answered your queries. Right. Let us see other queries. Very good evening, Achan. So even the partogram is changed, guys. Even the partogram is changed. We no more now we have. So we earlier had normal WHO partogram. First partogram was Friedman's curve, right? So after the Friedman's curve, we had WHO partogram. So after the WHO partogram, we have modified WHO partogram, right? So now we have WHO labor care guide, which is completely different. So watch out on the video of WHO labor care guide also. I'll be releasing this video, and we'll try to make it free for everyone by putting it in the YouTube also, WHO labor care guide. So see that definitely, because now we don't have alert line, action line, and it's a completely different module where they have given a lot of importance for companionship, and how the patient is, how comfortable the patient is, taking into consideration the patient's feeling, everything. There's a new WHO labor care guide. Okay. So Jay Shruti, whenever there's a break in the cord, you can do manual removal of placenta in the labor room itself. You don't require to take her to the OT unless until it is like accreta, percreta, increta. Normal placenta, you have to put your hand inside, then separate the entire placenta, right? So the plane of separation will come as deciduous spongiosum. And once you separate the placenta by this movement, then you hold it and pull it out. You don't require anesthesia. Okay. So best management for lung lesions, post-molar evacuation. So post-molar evacuation, if there are lung lesions, it means it is choriocarcinoma stage 3. So post-molar evacuation, if it has gone to the lungs, it is choriocarcinoma stage 3. But lung lesions are low risk. So you have to check the WHO scoring system, and if it comes as a low risk, then you can just give single agent chemotherapy. And if it comes as a high risk, WHO score comes high risk, then you have to give Emaco regimen. So I have a detailed explanation of this in the app, again in the gestational trophoblastic neoplasia topic. You can have a watch, guys. So Simran, your answer is you have to mainly go for chemotherapy, depending on whether it is low risk or high risk. If it is WHO scoring low risk, that is score less than 7, you can give single agent chemotherapy agent, that is methotrexate. If it is WHO's prognostic score more than 7, that is high risk, then you have to give Emaco regimen. Next, how to differentiate between septate uterus versus adhesion on the hysteroscopy. Both are completely different. Adhesions can be seen, and septate uterus, you will see two uterine cavities. In septate uterus, you will see two different uterine cavities. Whereas in adhesions, you will see the intrauterine adhesions, no? There won't, and the cornu also will be, the cornual openings also will not be clearly visible. Have an adhesions on hysteroscopy. So usually in hysteroscopy, when you are looking inside, you can't get confused between adhesions and septate uterus. Can you please tell about the Dhruv, the app not working is not, I think it's a minute temporary. So I think it will be corrected in another half an hour to 1 hour. So don't worry. And I'll definitely ask the team to look after it and inform you as well. No, Simran. If it is low risk, we give single agent chemo. Only if it comes into high risk, then you have to give Emaco regimen. Okay? Hysteroscopy only, you don't get confused in the septate uterus and intrauterine adhesions. To be frank, on HSG, you might get differentiate. On HSG, septate uterus will look like two uterine cavities. Whereas on HSG, Asherman syndrome will have honeycomb appearance, multiple filling defects. Actually, I can show you. Just give me 1 minute. So next, there's one question in FMG from this time. Horse placenta is ectodermal. What is the origin of the human placenta? Right. So Mullerian malformations, the first line investigation will be 3D USG. See, the first line investigation for Mullerian agenesis will be 3D USG or ultrasonography. Okay? Investigation of choice also you can go for 3D USG. Best to differentiate between septate and bicornuate is MRI. Investigation of choice, if you don't have 3D USG, then you can go for MRI also. Okay. Gold standard is hysterolaparoscopy. That is, you see from inside with the help of hysteroscope and you see from outside with the help of laparoscope. Okay. Right. So I hope this is clear. And I'll also show you the images of hysteroscopy. I'll show you the hysteroscopic image, guys. So you can keep posting till then the other queries. I'm not able to find it right now, but the two images of hysteroscopy will definitely be very different for, Asherman's as well as septate uterus. So human placenta will be mesodermal in origin. No, gold standard will be 100%. No, so gold standard you should see from inside, and from inside is seeing through hysteroscope, and you can also confirm by seeing it from outside, that is laparoscope. So gold standard is hysterolaparoscope itself. Okay. So for gestational diabetes mellitus, there is no need for postpartum insulin requirement. So post delivery, no need to give any insulin after just in gestational diabetes. Why? Because gestational diabetes mellitus is due to increased anti-insulin hormones in pregnancy, and all these anti-insulin hormones, that is human placental lactogen, estrogen, progesterone, all the cortisol, all these are mainly secreted from placenta. And once the baby is born, once the placenta is removed, this anti-insulin hormones are gone down. So there is no insulin resistance post delivery. So that is why post delivery in GDM patients there is no further requirement of insulin. Okay, right, Jayashruti? Most common site of injury to ureter is where it crosses the uterine artery. So in the Wertham's canal, where it crosses the uterine artery. Second most common site of injury to the ureter is when it is entering in the pelvic brim. Okay. Most common site during gynecological is where it crosses the uterine artery in the Wertham's canal, not at pelvic brim. So placenta is arising from the trophoblast. Trophoblast, that is both syncytio and the cytotrophoblast. So all those are of extraembryonic and extraembryonic mesoderm, right? So Simran, irregular ripening, irregular shedding, all these are outdated terminologies. Nowadays we are not using it. So irregular ripening is where we don't have sufficient amount of progesterone, because of which unopposed estrogen is causing only the growth of the endometrium, which is not having the edematous changes by progesterone due to deficiency of progesterone. So nowadays we just call them as anovulatory AUB. Yes, during PPH, uterine artery ligation, you have high risk of ureteric injury if you go laterally. Always, whenever you are ligating the uterine artery, or in hysterectomy or in PPH, so if you go laterally, there will be high risk. So that is why you should ligate it as near as possible towards the uterus. Okay, very good question, Ganesh. Topics important for CMS. So actually I have done all the past 5 years CMS questions. So I will try to send you, if you can DM message me, I'll send you the question papers of the past 5 UPSC CMS questions which I have done. Next, most of the time what I've observed is cervical cancer, they always ask question. And whatever you're preparing for your NEET, that is sufficient or more than enough for UPSC CMS. Somehow one topic I've seen every exam them asking question is CA cervix and CIN, HPV vaccination. So 1 to 2 questions will be definitely present from CA cervix. So please go through that topic. And somehow I felt they also like RH isoimmunization, because past 2-3 years there was questions from RH isoimmunization, prolapse, fibroid, all these management questions were there. Okay. Yes, so Jayashruti, why we do GTT after 6 weeks is just to reconfirm whether her sugar levels have come back to normal or not, right? See, most of the time, that is why I'm waiting till 6 weeks to reconfirm. And you should tell her in future she has high risk of developing diabetes. So she should, she should not, she should maintain the lifestyle modifications. Many doctors are studying as I used to study for UG NEET. Female impotence, I think what you're trying to ask me is regarding vaginismus. So vaginismus is a psychosexual disorder where the thought or the act of coitus literally scares the woman, which leads to the complete contractions of the vagina. So when there is vaginismus, one alternate which we can do for them is we can go for intrauterine insemination. So by that, they, even if they don't have coitus, they can have the pregnancy by using the IUI of husband semen. So you want me to discuss the MCQs for next 30 minutes? Right. So first and foremost, I will answer some questions which have been personally messaged to me through Telegram. So I'll take up those questions, and then we will see. So in the recent TND, we had one question, that is a pregnant woman at 31 weeks of gestation with hemoglobin 8 gram per deciliter. What is the management? So 8 grams is moderate anemia. So your management should go for oral therapy. But if you have less than or equal to 7 gram per deciliter, that is when going to severe anemia, you can give parenteral therapy. You can give parenteral therapy beyond 30 weeks of gestation. Beyond 30 weeks of gestation. Okay. So this was one query which was asked to me. Next. So what is the topic which you want the MCQs from obstetrics or gynec? So regarding the protocol of tetanus vaccination, so now we are supposed to give 2 doses of TD 4 weeks apart. You give 2 doses of TD 4 weeks apart. You repeat again booster dose if the next pregnancy, if previous pregnancy is 3 years back. And if any dose is given beyond 36 weeks, there is no benefit of it. So you have to immunize the baby as soon as the baby is born. Right. Yes, Kaustuv, both in oral and parenteral hemoglobin rise is equal. So that is why you're allowing, as it is just moderate anemia, you're just allowing her to continue with her oral therapy. So we'll do some labor MCQs. So identify the procedure shown in the image. So what do you think is the procedure which is being shown in the image here? So this is the Paulick's procedure, right? So when you put thumb on one side and 4 fingers on the other side, this is called Paulick's procedure, which is the third Leopold manual, So you all should know the Leopold methods. So this is the third Leopold method, right? So this one is the fundal grip. So this is the lateral grip or the umbilical grip. Fundal grip is Leopold first Manier. Lateral grip is Leopold second Manier. So when you put thumb on one side and 4 fingers on the other side, this is the Leopold third Manier. Leopold third Manier, or it's also called as Pollick's grip. Right? Only the fourth Leopold Manier is by seeing the patient's feet. Only the fourth Leopold Manier is by seeing the patient's feet. Right? So in the first Leopold Manier, when you're trying to feel the upper pole of the uterus, if you feel there is a soft, broad, irregular structure, then it is breech. Then it is breech. And if you feel there is a hard, curved, globular, hard, curved, globular and ballotable structure, and ballotable, then it is the fetal head. Okay. So second lateral grip is also called as umbilical grip. So in umbilical grip, if you feel there is a smooth curvilinear resistance, that's the fetal back. Smooth curvilinear resistance, that is fetal back. And if you feel there is multiple knob-like structures, then it is the fetal limbs. Okay. Pollick's grip, if the head is ballotable, not engaged. If head is engaged, it will not ballot. And in fourth Leopold Manier, which is to confirm the third Leopold Manier, if your both hands are converging, head is not engaged. If your hands are diverging, head or the presenting part is engaged. Right? So, a 35-year-old A 35-year-old nulliparous woman is in the second stage of labor and has been pushing for the last 2 hours and is exhausted. The cardiotogography is normal. The head is 1 centimeter above the ischial spine in occipito-anterior position. Which of the following is the most appropriate action? First, you try to attempt from your side. Then I will guide you through the question. So this is a very difficult, it's a good question. I feel you should try to attempt. So for this, whatever our notes we have wrote the table, no, that you should have in your, that you should be there. So now the woman is in second stage. So in second stage, primi, multi. On an average, prolonged second stage and second stage arrest. Right. So on an average, how much is the time duration taken for the primi to complete the second stage? It's 30 minutes, 20 to 30 minutes. Multi 50 minutes. So round figure I'm writing 60 minutes. 50 to 60 minutes you can remember. Right. So, sorry, I have written ulta. So primi, she'll take around 50 to 60 minutes to push the fetus outside. Multi, she'll take 30 minutes. Prolonged second stage is when the baby has not come out by more than or equal to 2 hours. Second stage arrest is when baby has not come out by 3 hours. Right? Similarly, for multi, it is 1 hour, 2 hours. Second stage arrest, your management should go for LSCS. Prolonged second stage, if baby's head is above +2, if station is above +2, means if head is high up, then you go for LSCS. And if station is below +2, then you can go for vaginal delivery. Then you have to go for vaginal delivery. Okay? So now, yes, very good, Jayashruti, excellent. I remember always it by 1, 2, 3. For primary, I remember 1, 2, 3. It's easy to remember like that, no? 1, 2, 3. Hai na? So 1, 2, 3. Now, please tell me what is the diagnosis in this patient. And if you have put the patient on epidural, for everything what I've written here in the table, you have to add 1 more hour. So first and foremost, you tell me what is the diagnosis for this patient. No, before you answer about the what should be the correct answer, what is the diagnosis here? So this is a nulliparous and she has been in second stage since last 2 hours and is now exhausted. So she is in prolonged second stage. Prolonged second stage, right? Hello Chiki, I hope you are doing well. Right? So why are we going for this patient when it is prolonged second stage? Very good, Ganesh. Very good, Jayashruti. Excellent. So, although it is prolonged second stage, why I am going for emergency cesarean is because head is 1 centimeter above the ischial spine. That is, vertex is at -2. -1. Vertex is -1. So, it is above +2. So, I told you when station is above +2, you have to go for LSCS. Now, if the same question would have been, head is 3 centimeters below the ischial spines, then what would have been your answer? Head is 3 centimeters below the ischial spine. Then what would have been your answer? So again it is in prolonged second stage, but station is below +2 now, right? Yes, now I could try for forceps. So then I'll go for trial of forceps in theatre. See, these are the some practice questions which we are doing from so long, like, before itself. Something very similar to this has come in the NEET also this time. So I think you should be trained with such questions so that you can answer very well in the NEET also and not be scared of such questions. So I hope all of you understood how to solve this question. Right, very good. So next question. A 37-year-old primary gravida attends the labor ward complaining of irregular contractions. So when there is irregular contraction, is it true labor pains or is it false labor pains? So first and foremost, 37-year-old primary gravida means she is elderly primary gravida. She is 38 weeks pregnant. The ultrasound scan performed at 36 weeks showed placenta to be posterior and high, with a normally grown baby. She conceived by IVF. Her admission CTG shows a baseline of 145 beats per minute, variability of 10 to 15, accelerations present, no decelerations. She's contracting once every 10 minutes. So her, yes, so it looks like a false labor pains because contractions are also once every 10 minutes and CTG is normal, right? So examination shows cervix to be partially effaced and dilated by 2 centimeters with intact membranes. The head is 5/5 palpable, means head is completely up. All her observations are normal. What should be your option which you would like to do for her next? So this is the elderly primigravida conceived by IVF. She has come to you with a normal CTG but with false labor pains with 2 centimeters dilated, that is in the latent phase, and head has not engaged. What will you or how will you manage her further? So would you like to do now, Chiki? Would you like to put her? Would you like to put her on continuous monitoring in from latent phase itself? So continuous monitoring is where you're going to give CTG, where you're going to put CTG. So usually you do continuous monitoring only in the second stage of labor, or from active phase you can do it by, like, if you really are getting scared. But latent phase mein we don't do continuous monitoring. Okay, let me go with one option here. So admit her to the labor ward and book her for cesarean. Just like that, you can't cut everyone, right? So you're not going to do cesarean for her as the CTG is normal, right? Admit her to labor ward and perform artificial. See, you should do artificial rupture of membrane for augmentation, but that should be done in the active phase or prolonged active phase or protracted active phase. She's in still latent phase, so you're not going to do that also here. I am not going to put her on continuous monitoring because she's still just in latent phase. As she is in false labor pains, but as she is a high risk woman, I am going to admit her to the antenatal ward just because she is conceived through IVF and she's elderly primigravida. If the same patient would have been 27 years, not conceived by IVF, spontaneous conception, then what would have been your management for the same patient? Yes, excellent, Jayashruti. So, normally in latent phase, you have to just give her rest. But why we are admitting her is because she is elderly primigravida and she is conceived through IVF and her head is 5/5 palpable. So, during contractions, if membrane get ruptured, there is high risk of cord prolapse. So, as it is a precious pregnancy, I am admitting her. But if this would have been any other patient, like low risk priming, I would have not admitted her. I would have just sent her home after giving her some sedation so that false labor pains will subside. Okay? Yes. So now you understood how again the questions can be and how you have to answer. And I'll tell you one update. So according to WHO Labor Care Guide, according to WHO Labor Care Guide, active phase now starts from 5 centimeters dilatation. Earlier active phase was from 4 centimeters, no? Now active phase is from 5 centimeter dilatation according to WHO. And according to Williams, active phase is from 6 centimeters. Okay, this is a new update again. This is a new update again. All of the following muscles are cut in episiotomy except So all of the following muscles are cut in episiotomy except. So we cut bulbospongiosis, we cut deep transverse perinae, and we cut superficial transverse perinae. We don't cut bulbocavernous. We don't cut bulbocavernous. So all the muscles which form the perineal body are cut except the sphincters. So episiotomy is a type of second degree perineal tear. Mediolateral episiotomy is preferred. We mainly cut bulbospongiosis and superficial transverse perinae. Along with this, levator ani and deep transverse perinae can also be cut. So you have to repair the episiotomy in 3 layers. So we use either vicryl or chromic catgut. So the angle is 60 degrees from the midline with respect to the stretched perineum. So post delivery it becomes 45 degrees from the midline. So if somebody asks you what should be the angle of episiotomy, you should tell 60 degrees from the midline on the stretched perineum. Post delivery it will become 45 degrees. Okay. And along with all this, you also cut some branches of pudendal nerves and pudendal arteries. So bulbocavernous right. Next question. A 20-year-old primary gravida is admitted to the labor ward in advanced labor following a pregnancy of unknown gestation. She is extremely distressed. Clinical examination reveals a uterine size compatible with 34 weeks of gestation. On vaginal examination, her cervix is 9 centimeters dilated and the fetus is presenting by the vertex in direct occipito-posterior position. And the presenting part is at the levels of spines. Continuous fetal monitoring is satisfactory. What should be the management? So she is in which phase of labor? So she is in which phase of labor, this patient? So she is a 20-year-old primary. So whenever you have a long question, always see the key points, age, parity, and she looks preterm because we don't know her gestational age. And she is now 9 centimeters dilated in OP position. Yes. So she is in active phase of labor with OP position. Is it an indication for forceps delivery? Why is it an indication for forceps or vacuum? So she's still at 9 centimeters. I can wait till she becomes full, right? OP need not to be done cesarean or vacuum or ventouse. We can wait and watch in OP. Why are we waiting and watching in OP? Because 90% of the patients in occipito-posterior will rotate 3/8 of the circle and deliver as occipito-anterior. Especially or when it is in direct occipito-posterior position, it can deliver as face to pubis. So I don't require to go for emergency cesarean or ventouse or forceps. She's still 9 centimeters. Let her become full and we know that there can be prolonged second stage, but we can still wait because there is a possibility for vaginal delivery here. So we have to wait and watch. There is no indication for any intervention here. Yes, long term will take time. So you can just wait and watch for the long term for happening, right? So I hope you understood how to solve the questions, right? So all the best, guys. Keep studying Any other queries before I end the session? Any other queries? So whether you're final year, whether you're third year, or whether you're an intern or post intern preparing for the obgyn, so I am always one message away from all of you. You can always message me whatever difficulties you are facing, whether in the preparation for obgyn in the app, or whether you have taken a live classes from me, or whatever, like any questions which you are not understanding or which you are not able to answer, you can always ask, right? So I have one more question, that can we apply forceps at station 0? So forceps at station 0. So we have high forceps. High forceps we don't use. Mid forceps is from 0 station to +2 station, right? Low forceps is +2 to +3. Outlet forceps are at +3 station. So mid forceps can be used between 0 to +2, but that requires lot of skill, and that we call it as mid axis traction. So you require lot of skill to do that. In modern obstetrics, it is a dying skill. Not everyone knows how to do that because lock doesn't happen. So mostly by another 1 week, already pregnancy and antenatal care. Okay, so mostly by next week, next Monday, we will have the updated video. Okay. I will definitely conduct Tiny CET November session practicing questions. I'll try to see that at least monthly once we have a proper organized question practicing. Okay. I'll do it, Cheeky. I'll do it. I'll definitely do it, Jayashruti and Cheeky. So actually in TND group, we are having some queries. I'll just address those queries if those students are attending here. Okay. So there is one question posted ki you have diagnosed a 21-year-old infertile woman with PCOS. So 21-year-old PCOS. The remaining infertility evaluation, everything is normal. HSG is normal and her husband's semen analysis is also normal. She get her cycles every 3 to 6 months. She's only 21-year-old. Okay. Which of the following treatment option is most appropriate first step in treating the patient to conceive, trying to conceive? So first OCP, option A, OCP, option B, spironolactone, option C, artificial insemination, option D, metformin. So here in this patient of PCOS, she is trying to conceive. Yes, Jayashruti, I'll be coming to Lucknow for face-to-face, definitely. Okay. So, if somebody is trying to conceive, can you give OCPs to them? Will OCPs benefit? Will OCPs make them conceive, or will OCPs stop the ovulation? OCPs can help only to regulate the cycles, and OCPs will cause an ovulation. So when somebody is trying to conceive, never give OCPs. Spironolactone will help in hirsutism, but here the problem is not hirsutism. Artificial insemination is not the problem here, it is the ovulation problem. So metformin can be used because one of the reason for all this happening is insulin resistance. By giving metformin, insulin resistance can be decreased. That's how testosterone can be decreased. and then peripheral aromatization to estrogen can be decreased, by which FSH levels can increase. So metformin induces or helps in ovulation. So when somebody is trying to conceive, you can give metformin so that she will ovulate naturally. Okay. Right. So the answer here is D, metformin. So this was one query I had. Okay, guys, any other queries, feel free to ask. I'll be always helping you out. So, thank you. I think all your queries are resolved, and keep waiting for the updated videos. So, there are exciting updates like now we have 4 trimesters in pregnancy. Not all updates you have to know, but yes, some updates definitely we have to know. That is, we have 4 trimesters in pregnancy now, and when all to give steroids, what is the importance of steroids. There are some silly mistakes in Williams also this time, there was one in the management of preeclampsia. It was given like you have to give steroids when there's a fetal demise. So I think that is a printing mistake, and yes, but there are updates also. Okay, so let us discuss the updates in our upcoming video, and WHO labor care guide, I'll release it in the YouTube itself. Okay, thank you guys, all the best, keep studying, thank you so much. Yes. So Shivam, 35 years old, presenting to you with postcoital bleeding. See, when somebody presents to me with postcoital bleed, there are multiple reasons why they can have postcoital bleed. But one of the reason which I have to rule out when somebody presents to me with postcoital bleed is I have to rule out the CA cervix. So if I have to rule out CA cervix, the best step will be, or the next step will be, I'll directly go for colposcopy. I'll not waste time doing pap smear and all that. So I'll directly jump to colposcopy so that I can confirm that there is no CA cervix, because I can't take a chance when there is a postcoital bleed. So it is a specific finding. Reason can be anything, but I will go for a specific investigation here. Okay. Yes, Rocky, after reading that 2 days, though, I was not able to come out of the trauma only. Okay, Shiva. Thank you, Selva. Thank you, all of you. Bye. Good night. Sweet dreams.